Good afternoon, everyone. Thanks for joining us today. My name is Punni Perumal-Swamy, and I'm a hepatologist at the University of Michigan and Ann Arbor Veterans Health Administration. And I am working in collaboration with the Michigan Opioid Collaborative to integrate additional Hep C resources. And as part of that today, we're bringing you part 2 in a 3-part webinar series. And today we're going to be discussing hepatitis C treatment. And there's been a number of changes, so I'm excited to share with you where we're at with things. All right. So here's the disclosure. So funding for this work does come by way of the Michigan Department of Health and Human Services as part of a grant-funded initiative to Michigan Opioid Collaborative. So the objectives today are really fourfold. Number one, I'm going to review pre-treatment evaluation for hepatitis C. 2, review treatment options for hepatitis C, and also talk through how to select various options. Number 3, discuss monitoring of hepatitis C. So how do you follow patients who you start on treatment? And then finally, we're going to end by discussing review of post-treatment monitoring a little bit. The first webinar, as you'll recall, kind of went over epidemiology and screening. Today's really focused on treatment. And the third webinar in this 3-part series is going to really focus on some additional key considerations. So I started the last webinar number 1, kind of highlighting the AASLD IDSA position on Hep C treatment recommendations, and that is that antiviral treatment is recommended for all adults with acute or chronic Hep C infection, except those with a short life expectancy that cannot be remediated by hepatitis C therapy, liver transplantation, or another directed treatment. So I think this is an important place to start, to just think about all patients you encounter who are living with hepatitis C as people that we should be thinking about treatment. So in the first webinar, we discussed screening and diagnosis. So today we're really going to talk about how do you do a pre-treatment assessment and then treatment and monitoring. So the goal of hepatitis C treatment is to achieve a cure. And a cure is defined as, the term we use is sustained virological response at 12 weeks. So what does this mean? This means that you have a negative hepatitis C viral load at 12 weeks after completion of treatment. And the reason this is important is obviously a cure is a nice thing to be able to say. There are not many things in medicine we can say we can cure, but this is now one of them. And what we do know is associated with the cures: reduced liver inflammation, reduced fibrosis or scarring in the liver, which can lead to improvements in portal hypertension, which are late complications of having a lot of scarring, or what we call cirrhosis, and a reduction in mortality. And I think these are really important factors as to why we want to think about treating all of our patients with hepatitis C, to reduce these complications from ever developing or reduce them from where they currently start before treatment. So we're going to start by talking about pre-treatment assessment. And from the pre-treatment standpoint, it's important to think about how we engage patients around treatment. And I think it really starts with the initial discussions that we have in our offices with these patients who are living with hepatitis C. So typically, initial things that we like to do include providing reassurance that hepatitis treatment is highly effective, it's easy, it's safe, and it's very well tolerated for the great majority of patients. And to also be aware of how difficult non-direct acting antiviral treatment was. And I think this is particularly useful in patients who are aware about the older treatments that we used to give to patients, because there's a lot of misconceptions still out there for patients living with hepatitis C. And these misconceptions may be informed based on prior treatment experience with some of these older, more toxic, difficult to manage treatments, or knowing friends or family or other loved ones who may have had experience with these old treatments. So as from the provider standpoint, it's good to have an awareness about what the differences are, because patients that you encounter in your practice may have opinions, ideas about what this treatment was like and what it is like, and may not know the differences. So the last important thing I would say is to really emphasize importance of adherence to treatment. That yes, these treatments are highly effective, they're easy, they're safe, they're short, they're very well tolerated, but that every pill counts. And that with treatments as short as 8 to 12 weeks, you know, and as simple as 1 pill a day, that every day counts, and that taking the treatment as prescribed is really important to achieving that cure. So a main question that often comes up is that there are so many options now. How do we choose the right one from the provider standpoint? And the good news is that they all work very well, incredibly well, and that the SVR or cure rates are consistently above 95% in clinical trials and in the real world. So we often look at the clinical trials thinking of that being the best case scenario, but we've now had more than 5 years to be doing this in the real world, and we're finding that the cure rates are just as high, and that the treatments are excellent from a safety and tolerability standpoint, and that there aren't many side effects, and that most patients make it through treatment without having treatment interruptions due to safety or tolerability or adverse events. And the other kind of major thing to keep in mind is that for most patients, any of the recommended options are likely to be fine. So it's just something to keep in the back of your mind, although I'm going to walk you through how to select treatment. So it's really important as part of your pre-treatment assessment to think about assessing a few additional things so that you have a really good grasp of where the patient is starting before treatment. So major things that we think about in terms of a pre-treatment assessment before selecting a regimen includes starting with a fibrosis assessment. And this is something that really needs to be done on every single patient living with hepatitis C. And I'll talk about how you can do that reliably and practically speaking in your practice. Genotype. Genotype is the subtype of hepatitis C. It's done through a blood test. And we'll talk a little bit about the trade-offs. I think the general sense is that this is a test that is still necessary in the scenarios that we're encountering. That might shift in the near future, and may already be shifting in certain places and going away with. The third thing is knowing whether or not a patient has ever been treated for hepatitis C before, because that also influences treatment decisions. So knowing whether a person's treatment naive, never been treated for hepatitis C, or has been treated before. And also being aware of comorbidities. So some things to kind of keep in mind would be co-infection with HIV, screening all patients also for hepatitis B, and also just being aware if they have chronic kidney disease, although this isn't as much of a deterrent as it was in the past. And then finally, having a careful review of the current medications a patient's taking and monitoring that on treatment, because there is a potential for drug-drug interaction with some of these medicines, but there are easy ways to do this that I'm going to show you how to do. So why do we care about a fibrosis assessment on every single patient? And I would just highlight here is that the real big thing that we want to make sure is that we don't want to miss cirrhosis. Cirrhosis is the medical term for that we call a lot of fibrosis or advanced fibrosis in the liver. And the presence of cirrhosis increases the urgency of treating somebody and may also affect the regimen that you select, the duration, and in some instances, the use of ribavirin, and risks or adverse events of therapy for these reasons. Also, it's important to know if somebody has cirrhosis because you want to have a careful eye around whether or not a patient has any history or signs of decompensated liver disease or portal hypertension. So you want to know if a patient has a history of ascites, varices, encephalopathy, other things that might give you pause in terms of proceeding with treatment or not. And also the importance of knowing whether or not they have cirrhosis before you start is because beyond Hep C treatment, once you have established cirrhosis before we start treatment, it's recommended that you undergo liver cancer screening or HCC screening. HCC stands for hepatocellular carcinoma. So again, really need to exclude current or past liver decompensation in patients with cirrhosis because this can really affect the treatment regimen choice and affects safety on treatment and how you monitor them, and also may change the setting in which the patient's treated in terms of general practitioner, internal medicine, family practice, versus sending them to a specialist to do the treatment and monitoring them or co-monitoring them with you. And if a patient does have cirrhosis, which is still an unfortunate final common pathway for patients who have had hepatitis C for a long time, it's important to do some additional assessments that, oftentimes in consultation with a specialist, we can kind of have a mind for. And these are things such as calculating the Child-Pugh score, calculating the MELD score, which take into account variables that kind of assess for risk of future decompensation. So again, cirrhosis just here at the bottom is really a stage of liver disease that you can get to with hepatitis C over a number of years. And things can influence the time to progress to cirrhosis, including concomitant alcohol use, other risk factors for other liver diseases. So really understanding and making sure a patient, if they have cirrhosis, we know that they have it or that we've ruled it out is important before we start. So how do we do a fibrosis assessment? There are a lot of non-invasive ways that we can easily do this in our practices. And these are some of the tests that we use to assess for fibrosis of the liver. I'm going to talk a little bit about the OPRI and the FIB4 test, and this is a test that it can be done anywhere by all providers, and it has very good negative predictive value to rule out cirrhosis. Another commonly used test that you might have heard about or have access to is something called a transient elastography with a test that we call the FibroScan. And there are cutoffs in the readings that indicate whether or not somebody has cirrhosis or an earlier stage of liver disease. And then there are a number of proprietary tests. These are serum blood tests with cutoffs that can be interpreted as having cirrhosis. So some of these tests you may have access to or heard of include FibroSure, FibroTest. A liver biopsy these days are rarely needed for these reasons that we have these above tests. And an ultrasound is not needed for all of our patients at baseline. Again, when we think about low threshold care and reducing barriers to initiating treatment, in young patients who are treatment naive, there's a very low risk of advanced fibrosis, and typically an ultrasound is not needed before you initiate treatment. Now, for patients with very advanced liver disease, the ultrasound can be used to look for structural abnormalities and also to screen for liver cancer. It can be somewhat insensitive in patients with cirrhosis, and it's only needed in a patient with cirrhosis to exclude HCC before you start. So what is a FIB4 assessment that I just mentioned we can all do in our practices? This is a calculation that includes 4 variables: age, your platelet count, the AST, and the ALT. And I never memorized this formula. There's so many nice online calculators that you can access. This one's at the University of Washington Hepatitis C website. But if you just Google FIB4 calculator, it'll take you to the same type of tool in a number of different places. And what you want to do is you can put in the age, and with the blood test you get on a patient, including the platelet, AST, and ALT, you put in these numbers and it goes into the formula below and it gives you a number. And if that number is greater than or equal to 3.25, this suggests advanced liver disease, stage 3 or stage 4 out of 4, which is what we call cirrhosis. So this is a nice test. It's non-invasive, just uses the age and blood test that you can get in the office. And this is one useful way to do a fibrosis assessment. So in your patients who are younger, who are treatment naive, they're more likely to be less than 3.25 when you do this most often. And this is a nice way to reassure yourself you don't have a patient with cirrhosis, but to understand what their fibrosis looks like. Another assessment that you can do in the office is the OPRI score. This is somewhat similar in terms of the variables to the FIB4 score, but it doesn't include age. So all you need is the AST, ALT, and platelet. So you need blood test results on a given patient living with hepatitis C. Anything over 1 suggests more advanced liver disease. And again, you can perform this on all patients. You don't memorize the calculator. You can just put it into Google and look it up. The idea being that any one of these fibrosis assessments, even our best fibrosis assessment, which arguably may be a liver biopsy or a transient elastography, is not perfect. So it's often recommended that we think about doing more than one fibrosis assessment to really be confident that we have ruled out that we're dealing with somebody with cirrhosis. Now, I've mentioned transient elastography using FibroScan. This is a test that uses a propagation of mechanical shear waves from the skin on the right side of the abdomen. It goes through the skin, hits the liver, and comes back to the probe to measure how stiff the liver is. And we typically want to get several measurements that are in a good range, and the machine kind of helps you with some of that. It does require some human interpretation as well to know that you have a good quality study. And the shear wave propagation map tells you whether or not you think you are hitting the right tissue, and then also outputs a number. And that number then translates into a fibrosis score, stage 0 to 1, all the way up to stage 4, or cirrhosis. It's a very reliable test. It's non-invasive. It does require patients to be fasting for 3 hours prior to doing it. There are some limitations in doing it in patients who have obese abdomens, where the measurements may be a little bit less reliable. And there's still an access issue. This isn't available in all places across the United States, although many major academic centers, tertiary care centers often have this, and some other radiology practices in the community now are acquiring these as well. So there are a number of proprietary tests I mentioned, and additional biomarkers or ways to assess fibrosis. I think the bottom line is to think about using more than one assessment when you're doing these less invasive tests, and that will increase your accuracy. And really what you want to know is, does somebody have cirrhosis, or have you ruled them out for cirrhosis before you start, because the management and treatment all changes. So where are we at in terms of whether or not we can avoid genotyping? I would say the short answer to this question currently in the United States is not quite yet, no. Payers in many states still continue to require the genotype be reported on what's called a prior authorization form. It's a form that in many places is required on behalf of the payer to submit. And one of the boxes most commonly on this form includes what subtype or genotype. So this is an additional blood test. The good news is that in Michigan, as of April 1st, Medicaid no longer, April 1st of 2021, Medicaid no longer has a prior authorization. So technically no genotype test is required. So this is something to think about in patients who are treatment naive and who do not have cirrhosis. And then, I think this landscape is somewhat shifting or changing, and there could be a role to not having to do the genotype kind of as regularly as we have been doing in the future. And there's some, potential trade-offs. Every additional kind of blood test that we make patients go back and forth for is an opportunity to lose a patient in the engagement process. It can delay treatment. A number of things can happen to a patient between when you get that test result and then bringing them back for the next step, which is to write the scripts and initiate treatment. I think where it's still helpful is in patients with advanced liver disease, in which they may have also seen treatment previously. So I think for these reasons, it's not quite ready to be done away with, but in certain scenarios, I think we selectively thinking about whether or not we could do away with it. And I think this area is going to be shifting, changing a lot in the future. So what are the recommended treatment regimens? Well, the nice thing with hepatitis C now is that we have what we call genotype specific regimens. So one in which that is informed based on the specific subtype of hepatitis C, or really now the simplified approach, what we call the pan-genotypic approach, where we have treatment options that cover all the genotypes, which is really what feeds into the concept of, or the question of, do we really need the genotype? If we have a treatment that works across all genotypes, what does it matter if they're subtype 1, 1A versus 2? And I think this concept of treatment becoming more simplified is one that is enabling us to get treatment out to the places where people living with hepatitis C are. And so you will find that many states like Michigan are now moving towards really embracing pangenotypic options as part of payers that they're working with. So the pangenotypic options for hepatitis C currently are sofosbuvir, velpatasvir, so that's what's known as Epclusa, glisaprovir or pibrentasvir, which is also known as Mavyret, or sofosbuvir, velpatasvir, voxiloprevir, which is known as Vozavy. Vozavy out of those three is usually used for retreatment or salvage therapy. So somebody who's previously been treated with Epclusa or Mavyret can be treated with Vozavy. So we generally, in a patient who's never been treated, we save Vozavy in case retreatment is needed for a specific reason. And the most common treatments that you'll probably see and start to use in practice will be one of the other pangenotypic options listed above. Now, if you work in a setting in which genotype is still required, or you're in your setting that sometimes there are contractual relationships, depending on if it's a correctional facility or certain places where the genotype-specific regimens are still relevant. And so it's good to have some awareness and knowledge about that, even though they're a lot less frequently used in common practice, I would say, these days. Genotypic specific regimens include elbasvir, grisoprovir, which are really aimed at genotypes 1 and 4, or ladipasvir and sofosbuvir, which really work the best for genotypes 1, 4, 5, and 6. So you can see there's a gap for patients who are genotype 2 and 3 with these genotype specific regimens. So we kind of introduced this concept of simplified treatment, like thinking about that there are treatments that now treat any genotype. So the genotype information is a little less important. So I think for patients who are treatment naive without cirrhosis, the AASLD and IDSA have put forward guidance around opting for a simplified regimen. So really anybody who's never been treated and who does not have cirrhosis, which is going to be a lot of the young patients now living with hepatitis C, will fall into this category. The simplified approach is one that you can think about. So these are really two options in terms of starting, right? Sofosbuvir and velpatasvir, and glisaprovir and pibrentasvir. These are really the two pangenotypic options that we start with. And in terms of how do you select one over the other, it's really a choice between you and the patient. I have put together some additional information here, including the duration. So sofosbuvir, velpatasvir is typically given for 12 weeks, and it's given as one pill once a day with or without food. So it's a little bit longer treatment course compared to Mavyret, which is for most patients 8 weeks, and it's 3 pills though, and it needs to be taken with food. So you can see there are trade-offs, and these are things that you can individualize and tailor to the specific patient that you're dealing with. The other thing to be mindful of is drug-drug interactions, and that might also influence which of these options you end up going for. And then, a couple of secondary things to think about is are patients able to take 3 pills all at once? Some people have issues with pill burden. They're both once a day. And then also the other point I would just mention is that some of our patients are living with food insecurities. And so taking medications with foods is not always an issue for all of our patients, but it could be for some of your patients. So just to keep these things in mind. So I'm not going to get into all the studies that led to the approval of these medicines, but there's been a lot of really great work done through clinical trials and then also in real world studies that led us to not just approval, but widespread use of these treatment options. So the data for sofosbuvir, velpatasvir for 12 weeks was shown in the Astral 1 and 3 trials, and really showed an excellent job in terms of curing patients with hepatitis C across genotypes and in patients without cirrhosis. And the same thing was shown for glisaprovir, pibrentasvir, or Mavyret, and this is with 8 weeks of treatment without cirrhosis across all of these genotypes. And you can see the SVR rates anywhere from 95 to 99%. Again, want to make sure that you have all the information in terms of selecting the best regimen. So these, in terms of who's ideal for simplified treatment, are treatment naive non-cirrhotics. So in patients with no cirrhosis, soft belpatisphere, which is Epclusa, is for 12 weeks. Mavyret or glisepivir, prenasir is for 8 weeks. For cirrhosis, if you do have a patient with cirrhosis that you're treating, so these would be 12 weeks again of Epclusa, and here the treatment time with Mavyret increases from 8 to 12 weeks. And then in decompensated cirrhosis, and this is a really important point that I was trying to kind of hint at earlier, is that the risk of treatment goes up. So you could still consider 12 weeks of treatment with Epclusa, but protease inhibitors with the Mavyret is contraindicated. So there are increased risks from a liver standpoint and making the liver disease actually worse in patients with decompensated cirrhosis and treating them. So the dosage for both of these is still 1 tablet for Epclusa, which is a combination of 400 milligrams of sofosbuvir, 100 milligrams of velpatasvir once daily with or without food. And with Mavyret, it's 3 tablets taken all at once, 100 milligrams of glisepivir, 40 milligrams of prenasir per tablet once daily with food. Side effects are fairly uncommon, but the most common ones that can happen in up to like 5 to 10% of patients include headache, fatigue, mild nausea, insomnia and asthenia have been reported with Epclusa, and headache, fatigue, and nausea with Mavyret. So most patients might experience or report these in the first several days of taking treatment or the first couple of weeks, but either the symptoms tend to abate after they continue treatment. So we really try to encourage patients that if they can continue to keep taking treatments despite having adverse events, if they're very mild and manageable. What are some other considerations in terms of pretreatment? It's important to understand what the status of the hepatitis B and HIV is in a patient before we start treatment for Hep C. So testing for Hep B and HIV is very, very important. And this is also because of shared routes of transmission, right? These are all bloodborne infections. And knowing whether or not somebody is surface antigen positive, meaning they have chronic Hep B infection, is very important. And we're going to talk in webinar 3 about co-infection with hepatitis B and C and reactivation of Hep B in patients who are either surface antigen or core antibody alone positive. So we'll have more information about this, but you need to test everybody for Hep B with surface antigen, core antibody, and surface antibody before you start them on hepatitis C treatment. So it's everybody with hepatitis C needs to be screened thoroughly for Hep B and also for HIV. Again, all of these things are bloodborne infections. We have seen an increase in terms of opioid use disorder related infectious complications. These are all considered infectious related complications that we are seeing a dramatic rise in. And so we need to be vigilant and know before we start treatment if they have these other conditions, because it may influence whether or not you put them on treatment for HIV or Hep B before. What's the story with chronic kidney disease? The good news is that there's actually no dose adjustment in direct-acting antivirals when using the recommended regimens. So elbasvir, grisopivir, ledipasvir are primarily hepatically metabolized with minimal renal elimination, so are fairly safe. The FDA amended package inserts for sofosbuvir containing regimens to allow use in patients with kidney disease, including those with a GFR less than 30. So before these package inserts were revised, we would avoid sofosbuvir in patients with GFR under 30, but that's no longer the case. And this includes patients on dialysis. There has been reports of colchicine-induced rhabdomyolysis in patients with renal dysfunction being treated with Harvoni, ledipasvir, and sofosbuvir while continuing atorvastatin. This is a very specific combination of medications that can lead to adverse events to be aware of. So it is very important before you select a treatment regimen to review a patient's current list of medicines and be aware that there are potential drug-drug interactions before starting hepatitis C treatment. I've listed some common or key drug-drug interactions, DDIs, here. So I think one of the take-home points here is not only get a clear list of prescribed treatments the patient's on, but a lot of our patients take a lot of things over the counter, and over-the-counter medicines often are not like prescribed, and patients may not always think of them as medications that they're taking. So it's really important to ask them, are you taking anything over the counter, any herbal supplements and other things? And where possible, things can be stopped if a patient's willing to stop them while they pursue treatment for 8 to 12 weeks for hepatitis C if there's any concern. And I'll show you another way you can check your drug-drug interactions, including discussing it with your pharmacist that works with your practice, or individual pharmacists that patients are getting their medications from. So the folks at the University of Liverpool have developed a really outstanding drug-drug interaction checker that's available for free online. You literally put in HCV drug interaction check, and this is the top website I think you're going to get navigated to. But essentially you can put in the Hep C treatment regimens and then any other treatment the patient's on, and they have a pretty exhaustive list, and it'll give you an output as to is there a potential or definite interaction, or is there no interaction. So this is often like a tool I do use very regularly in addition to talking to my pharmacist in-house. The other thing to be aware of is that a lot of times your electronic health records that you're working in have a drug-drug check system built in. And this is another way, if you prescribe the treatments through your electronic health record, might be able to check for drug-drug interactions in this way as well. So kind of some important things in terms of when to think about referring a patient. So a lot of what we have been working with providers in the community to do is to really build capacity out in the community. And Hep C treatment, by and large, does not need to be done by specialists. It doesn't need to come to infectious disease and hepatologists and gastroenterologists. There may be some notable things to think about, though, in terms of when to refer a patient to see a specialist, notably a gastroenterologist or a liver specialist, a hepatologist. And I think this might be like if you suspect somebody does have cirrhosis, that would be a good person to send for a consultation. And oftentimes you'll find an openness or willingness to often co-manage patients with you in the community, especially if distance and access to specialists is a problem. Some of those things have been improved with the expansion of telehealth, especially during the last year with the COVID pandemic. However, there's still a digital literacy divide and not always access to the tools needed to be able to do telemedicine. But so cirrhosis may be an indication to refer a patient. Also, if the patient, when you screen them for hepatitis B or HIV, those tests come back positive or they're known to have those things before they're diagnosed with Hep C, those could be reasons to refer to get some additional input on how best to manage it. It doesn't mean we can't treat the hepatitis C. In fact, we actually do want to treat the hepatitis C in that scenario because of the risk of accelerated liver disease progression with more than one of these viruses present, but doing it carefully and making sure that you're not going to run into problems with the hepatitis B and the HIV by curing the hepatitis C is important. And then other things to think about is that if you encounter a patient who's been treated before and failed, and has failed an all-oral Hep C regimen or had a treatment interruption, it might be helpful to strategize or meet with the specialist to try to talk through what is the best way to try to get them treated one last time to get them to achieve a cure. Important things to be aware of is that the old treatments, which include boceprevir, telaprevir, pegylated interferon, and ribavirin, failures with any of those treatments are now considered treatment naive in terms of being able to move forward with one of the new treatments. And then finally, in patients who do have cirrhosis or even F3 or F4 fibrosis, these are patients who are going to need to engage in liver cancer screening, HCC screening long-term. And there's maybe a comfort level to be doing that in terms of the community setting in which you're practicing. But also, I think we recognize that not all community providers are going to have a comfort level around that. So sending them for consultation to monitor and do the HCC screening for you can sometimes be considered. So what does the landscape here in Michigan look like and what changes have come about? Well, I think it's definitely is an exciting time to be talking about eliminating Hep C in the state of Michigan. And I think, certainly the Michigan Department of Health and Human Services, along with many stakeholders, including Michigan Medicaid, have been working hard together to try to eliminate barriers to get treatment out to patients, and providers also to learn more treatment and what's new with treatment, to be able to do it in a variety of settings. So as of April 1st of 2021, MDHHS actually launched the We Treat Hepatitis C initiative. And this is Michigan's state plan on eliminating hepatitis C. And as part of this, they have worked with Michigan Medicaid to now eliminate the prior authorization requirement for the preferred pangenotypic MAVRIT treatment. So they had a whole call for applications from pharma companies to compete, essentially. And in the end, they went with the pangenotypic regimen of MAVRIT. So they also, with doing away with the prior authorization for Medicaid patients, means that they've also eliminated restrictions around sobriety and drug use and need for abstinence or information around these things in individual patients, which have been barriers to getting patients treated, when we know that we can often safely and effectively get these patients treated, even if they have ongoing or recent drug use or alcohol use. So as part of this, the state of Hep C, which is kind of a group that's looking at Medicaid access to hepatitis C across various states, has now given Michigan an A+ rating in terms of eliminating prescribing restrictions. So this is the best place really to be in terms of trying to get more treatment out to patients who need it. And the great thing is that with Michigan Medicaid eliminating the prior authorization for the preferred MAVRIT, so that means if you go with a non-MAVRIT as your first time treatment, you would need to still fill out a form to get approval for, let's say, the other pangenotypic regimen we mentioned, which was Epclusa. And I believe that that form does not include sobriety restrictions on that as well. Michigan has joined 6 other states in now eliminating their prior authorization for Hep C treatment options. And we're now on the map, as I like to say, in terms of HHS tracking what states are doing. So we have a lot to be really proud of in Michigan here, really led by efforts at Michigan Department of Health and Human Services, and specifically the viral hepatitis unit, moving the needle here. So there are opportunities for you to have support. We are working with providers across the state, particularly in rural and more remote parts of the state where access to specialists remains a challenge. And we're also faced with, now we have great treatments, and we know that a lot of patients are in the communities where they're not having access to specialists. And we want to really be on board with where we're going with eliminating as many barriers as possible and just providing support or a bridge for those providers who are seeking it. So as part of that, we are offering optional biweekly case conferencing here in Michigan through the Michigan Opioid Collaborative Integration of Hep C Services. This is a group, it's a really wonderful group. I feel lucky to be a part of. We meet every other Friday from 9 to 10 in the morning and just discuss cases. And we discuss, most of these cases are in young patients with opioid use disorder. So we not only talk about Hep C, but we talk also about opioid use disorder in some of these cases. So it really promotes a lot of cross-learning between all of us. And it's really been a mix of providers coming together. So primary care, family medicine, addiction medicine, and hepatologists as well. And you can always submit cases to be reviewed as this process. Happy to review cases by email or by phone. We actually use a templated form that's really easy to fill out. It's 1 page. And signing a consultation to submit with your prior authorizations, which by and large for your preferred pangenotypic MAVRIT option, you will no longer need. And our plan is to disseminate this finding in this model so that Michigan can really be a role model for other states in terms of where to go with building capacity. So I just want to end by giving a shout out to the Michigan Opioid Collaborative Program. We have a lot of wonderful resources on this website. If you go to About MOC, you'll see a hepatitis C tab, and that's where this webinar and all 3 webinars, when the 3rd one gets recorded, will be available. The slides we're also looking into being available for download. And there's also additional resources around Hep C and opioid use disorder that you can find there. So please check us out. I wanted to just end on a couple of notes about treatment and monitoring patients. It's really important when you are treating patients for Hep C, and this is really taken from the ASLD IDSA guidelines, to monitor patients with diabetes, to watch their finger sticks to make sure no hypoglycemia occurs with treatment and taking medicines or taking it with or without food. Inform patients taking warfarin of potential for changes in their anticoagulation status, specifically if the INR becomes subtherapeutic. And in-person phone visits can be scheduled if needed for patient support to assess their symptoms, see how they're doing based on individual cases. And then in terms of monitoring your treatment plan, I think this is really somewhat up in the air. Certainly a pre-treatment evaluation needs to be done. You need to know where you're starting, make sure that a virus load is present, what their CBC and CMP shows, because that will help you do at least a FIB4 and OPRI score in your practice. And then really checking for blood work. Usually a lot of patients or providers will say monthly on treatment. So maybe at week 4 and week 8, depending on your patient and their ability to come in and be monitored. And then at the end of treatment, you certainly want to get labs. And at the end of treatment, you expect your Hep C RNA to be not detected. And then what you really want to follow them out for, oftentimes, again, we'll say come in monthly off treatment for the first 3 months to see if you've achieved a cure at 12 weeks off treatment. So this can really be individualized to your patients. I put like in black the X's where I think definitely we would recommend you get blood test monitoring, and then to really consider for the gray X's here for individual patients what makes the best sense. The things to also keep in mind is that, you know, it's somewhat simpler to tell patients we're going to monitor your blood work monthly for the duration of the next 5 to 6 months. So 8 to 12 weeks of treatment and 12 weeks off of treatment to determine cure. So this whole process is going to take 5 to 6 months. Hep C antibody will be reactive lifelong. So that's a marker forever being infected. So even once you achieve a cure, the antibody still stays present. It's again, just a footprint that you ever had infection. And then in women of childbearing age, it's important to check a pregnancy test prior to starting. Current recommendations are not clearly to pursue treatment during pregnancy because of the limited data on safety, although that also will be potentially shifting in the near future when more data becomes available. And I'm going to be talking more about that in the 3rd webinar, so stay tuned for that. And in patients, particularly those with prior Hep B infection, they should contact their provider if they experience any unexpected or severe symptoms. And then again, at least 12 weeks after treatment completion is needed to confirm whether or not a patient has been cured. And if the Hep C RNA remains detectable 12 weeks after treatment or comes back after 12 weeks after treatment, I think that would be a time to think about discussing this case with a specialist if you feel that would be helpful. And then at least 12 weeks after treatment completion, obtaining the ALT and the RNA. In somebody in which the ALT remains abnormal on repeated measure after they've been cured for hepatitis C, you may want to consider also referring those patients to a specialist just to make sure there isn't any other monitoring or workup for other liver diseases that patient needs. And then finally, post-treatment follow-up. So I wanted to kind of clearly, again, go over what does it mean to be cured 12 weeks after ending that last pill of treatment. If it's 8 or 12 weeks of treatment, you follow them for 3 months, then you check their Hep C RNA. If they're not detected, they are cured. If they are detected, they are not cured. And we need to evaluate all of those patients for retreatment with or without a specialist. And I think in that context, if retreatment is needed, it's really important to try to identify why that patient was not cured and address that prior to retreatment, because really, like, as I mentioned, more than 95% of patients are going to get cured. So a lot of times it's because treatment was interrupted, there was a reaction, something else happened, or they may have had a drug relapse, they may have been incarcerated, there may be other reasons that are addressable and should be addressed before starting treatment again. And then in patients who are cured, it's important to monitor for reinfection if the risk is ongoing, at least annually. So if you have a patient who is still engaged in drug use, particularly injection drug use, those patients need to be tested annually with a Hep C RNA. Because remember, they're now antibody positive for life, even after they're cured. So the only way you're going to know whether or not they have it is by checking the viral load once a year. Some important kind of post-cure things that I like to encourage providers to all do is to, one, congratulate their patients and yourself for curing their hepatitis C. Inform patients who are cured they're going to be susceptible to reinfection if the risks are ongoing. So a cure doesn't mean you can never get it again. So it's really important to provide patients with the best Hep C harm reduction resources to minimize possibility of reinfection, and that might include referral to syringe exchange programs if drug use is ongoing. And no liver-related follow-up is recommended in patients who don't have cirrhosis or F3 fibrosis who achieve a cure. So those patients can be told you're cured, you're done, you don't need to have additional liver follow-up. Now, in patients who do have cirrhosis or have F3, those patients need liver cancer surveillance with an ultrasound plus minus an alpha-fetoprotein every 6 months, lifelong, even after they're cured. And all patients are advised to avoid excess alcohol use because they've already had one chronic liver disease that's been cured and there may be some amount of fibrosis. So it's important to avoid excess alcohol use. And in patients who do not achieve a virological cure, patients in whom initial Hep C treatment fails to achieve a cure should be evaluated for retreatment, oftentimes with a specialist in accordance with the AASLD IDS-8 guidance. And until retreatment occurs, assessment of disease progression every 6 or 12 months with hepatic function panel, CBC, and INR is helpful, so you can monitor their FIB4 going forward. And again, advise all of these patients to avoid excessive alcohol use so it doesn't accelerate their risk of developing chronic liver disease. And then some additional kind of post-treatment monitoring expectations. So in patients with cirrhosis, they are at risk for liver cancer. They are at risk for other complications related to liver disease and need to be monitored in some ways, at least every 6 months. And if you have ongoing reinfection risk, to do a Hep C RNA even after they've been treated and cured at least once a year, but 6 to 12 months in some of the other guidances. And if you have no ongoing exposure, an annual ALT and promoting liver health, minimizing excessive alcohol use is the promoting liver health here. And then reminding patients not to panic if their Hep C antibody tested is checked by another doctor, because that is expected to be positive lifelong. It's really a marker for ever having been infected, and it doesn't go away with a cure. So just to kind of recap everything, so any patient with a new hepatitis C diagnosis should be evaluated for evidence of advanced chronic liver disease. You want to make sure if a patient has cirrhosis, you know that, or if they've been ruled out, great. You want to screen them for other bloodborne infectious pathogens, including Hep B and HIV. And candidacy for potential treatment. And I think this really needs to be individualized. We're really trying to go with low threshold, low barrier approaches. So even in people with active drug use can be considered. And it's really important to counsel patients on reinfection risk and harm reduction if they're open to that. Other ways to protect from additional liver toxicity is to check their Hep A and B status. And if those are negative, to vaccinate them. Reduce or discontinue alcohol consumption so that we don't accelerate disease progression, and avoid new medications, including over-the-counter and herbal medications during treatment. And they should be, counseled to reduce risk of transmission. So now all blood in the United States gets screened for hepatitis C, and to not share drug use equipment or other appliances that might come into contact with blood, including toothbrushes, dental appliances, razors, and nail clippers is also recommended by the societies. Here's a summary slide with all of those assessments that you can just navigate to check your drug-drug interactions, do your fibrosis FIB4 calculation, the AASLD guidance, and the MOC website. I think this might be my last slide. Hep C assessment and treatment have been simplified. Fibrosis assessment is key before you start. Genotyping is still required by most payers. Hopefully that will be shifting soon. pangenotypic regimens for most, if not all settings. So there are at least 2 really great options that are being used a lot now. And on-treatment monitoring can be tailored, and post-SVR follow-up is limited to liver cancer screening for those with cirrhosis before you start, and Hep C RNA annually, at least for those with ongoing risk exposure. So this again is just a summary of all the resources that you can find on the Michigan Opioid Collaborative website, including our case conferencing and webinar information as well. And that's it. Thank you very much.